I'm Dr. Afzal Sohaib. I'm a cardiologist from London, and it's great to be back at the ESC Congress in Barcelona after a 3-year break. And I'm going to talk about my top 3 trials which I've seen at the Congress so far. The first one I'm going to talk about is the eBRAVE study. So this looked at screening people for atrial fibrillation. We know that there's a large population of people who have AF who don't know, and so are at an increased risk of a stroke. So finding these people is really important, and the eBRAVE study looked at the use of a smartphone detector, smartphone camera to detect AF using a PPG monitor. So this was a non-site specific study. Basically, in Germany, they took people who were registered with one of the state insurance schemes and invited them to participate and sent them out the app. It was a randomized study, very large. 8% of the participants who were invited responded, and the detection rates for AF were significantly higher in the patients who used the camera phone app to detect AF. It was 1.3%. It was almost double the number of the control arm. And importantly, this was clinically significant AF, and these were people who were started on anticoagulation. This is huge potential because it's something which is scalable. Most people have a smartphone these days, and we can use either hospital records or insurance records, as it was in this case, to identify which people would benefit. The second one was the CAPLA-AF study. So I ablate atrial fibrillation, and patients with atrial fibrillation, which is persistent, can be particularly difficult to ablate. Long-term success rates are poor. So this study from Australia looked at whether adding in posterior wall isolation to the conventional ablation which we do, which is pulmonary vein isolation, would improve success rates for AF. They had about 3 to 350 patients. It was randomized, and there was no difference between the two arms. There's been lots of controversy about whether doing anything more than pulmonary vein isolation is of benefit for AF, and this is another well-designed, robust, randomized controlled trial study which showed that it did not add anything more. My final study is the INVICTUS trial. This looked at anticoagulation in patients with atrial fibrillation who have rheumatic heart disease. This is a particularly big problem in the developed world, so a big group of people. Monitoring anticoagulation with warfarin can be quite troublesome, measuring INRs, attending follow-up clinics. So actually, if these patients are adequately protected with a DOAC, then potentially that can be a game changer in this setting. So in this study, they looked at about 4,500 patients. They found that the group who were randomized to rivaroxaban, which was the DOAC they chose, did not benefit compared to warfarin. Rates of death were actually higher in the rivaroxaban group. It was designed for non-inferiority, but actually we saw superiority with warfarin or other vitamin K antagonists which were used in that arm. So I think that has really important real-world implications, and it means we can't just use DOACs in all settings across the board. Clearly, in some cases, vitamin K antagonists are better than DOACs.